All right. Hello and welcome. Let me make sure we get our slides up here and we're ready to go. Welcome to the Montana State University College of Nursing Center for Interdisciplinary Health Workforce Studies spring webinar series focusing on the workforce serving frail older adults. We are pleased to have you joining us for today's webinar. My name is Christy Friedman and I'm the program manager for the center. A couple of center announcements before we begin today's webinar. We recently released fourth quarter 2017 RN employment data showing a sharp increase in employment in non-hospital settings, as well as a rise in employment across all age groups. Visit our website for a full look at this data. Second, join us in Bozeman, Montana for Healthcare at a Crossroads. Where do we go from here? A free conference, April 5th through 6th. Dramatic changes in technology and innovation, evolving demographics and delivery models, and changes in federal and state healthcare policy regulation have put the United States healthcare system at a crossroads. Join this dynamic event featuring national and local experts on consumer-centric healthcare, evolving federal healthcare policy, enhancing behavioral health integration, promoting community health, ensuring healthcare for aging and vulnerable populations, maintaining a robust healthcare workforce, and more. You can find links to a full agenda and registration on our website at healthworkforcestudies.com. Now, turning to today's presentation, after the speakers conclude their presentations, we will have a 15 to 20 minute time period available for discussion and Q&A. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. We are also recording the webinar today, and we'll post it to the center's website. You can also find previous webinars and presentation slides for many of the webinars we've done within the video library tab on the center's website as well. You may remember our last webinar touched on the genesis of this series and focused on the results and data from site visits and focus groups and looked at the composition of care team models. You can find this recorded webinar on our website as well. And today's webinar is going to build on that foundation and examine care management in 2 hospital systems serving frail older adults. With that, I'd like to take a moment to have Peter Bierhaus, Center Director, introduce our 2 speakers. Peter?
Hey, Christy, thanks very much. I'm broadcasting here from Bozeman, Montana, where we've got some beautiful spring-like sunny weather out. And newsflash, everybody, last week our first grizzly bear was spotted coming out of a den, so we know now spring has finally arrived. So we're delighted about that. But I'm actually much more delighted that our center is working with Dr. Karen Donelan and her team at MGH and Harvard Medical School on this webinar series and in the broader initiative that she's undertaking. We all know about many of the issues surrounding our aging society and the increasing challenges and yet the increasing opportunities to do well for our nation's older population and frail elderly as well. Today, we're going to learn a lot about 2 different approaches that major hospital systems and care delivery systems are undertaking to respond to this challenge. And I'm going to get right at introducing our 2 presenters. The first is Dr. Nicolas Oreskovic, who is an internist and pediatrician and clinical researcher. He is the medical director for the Integrated Care Management Program at Massachusetts General Hospital, where he is also responsible for overseeing a team of specialized care coordinators made up of nurses, social workers, community health workers, and community resource specialists who provide health promotion, chronic disease management, and care coordination for high-risk adults and complex medical conditions. I can't wait to hear how you're doing that, Nicolas. He's also an assistant professor of pediatrics at Harvard Medical School. His research interests include better understanding how health behaviors and different care delivery models impact chronic diseases over the life course, the use of technology to improve health behaviors and healthcare delivery, and understanding how the built environment, including architecture and urban planning, can affect individual and population health And I can tell everybody, Nicolas has survived the 25th nor'easter of the winter so far. So we're glad that you made that, Nick. Next after Nicolas is Robyn Golden. Robyn is the Associate Vice President of Population Health and Aging at Rush University Medical Center in Chicago. Robyn holds an academic appointments in the departments of medicine, psychiatry, nursing, and health systems management. She packs it all together. Robyn is responsible for developing and overseeing health promotion and disease prevention, mental health, care coordination, and transitional care services for older adults, including family caregivers and people with chronic conditions. Robyn is key to the development of the interprofessional models of care for Rush's population health programs. Robyn also is the principal investigator for the Health Resources and Services Administration funded Geriatric Workforce Enhancement Program and the Commonwealth-funded Primary Care Redesign Project. And for over 30 years, Robyn has been involved in service provision, program development, interprofessional education, research. It goes on and on. In fact, I could spend a lot of time just talking about Nicolas and Robyn, but let's stop the talk and get right over to Nicolas and have you begin. So Nicolas, I am passing the microphone to you.
Thank you, Peter, and thank you for having me. So today I'm going to talk about our community and systems-based model of care management to support frail older adults living in the community at Massachusetts General Hospital, the program we have there. Next slide. So just quickly an overview of the talk that I'll be giving today. I'm going to start with an overview of the program and the model at Massachusetts General Hospital that we use to provide this care coordination. Then I'll touch upon the population that we serve. I'll get a little more, give a little more detail at that point about the staffing that we use in this program and the role of the care manager, or what we call the care coordinator. I'll touch on areas of assessment programmatically that we look at and the types of services that we deliver. I will discuss measures and outcomes. And then finally, I'll wrap it up with some lessons learned over the years in terms of successes and ongoing challenges. Next slide. So quickly to go over the program and the model, we are within the hospital network. We're a hospital-based program within Massachusetts General Hospital, which is a major academic medical center in Boston, which is part of a larger hospital network called Partners. And the program itself, the Integrated Care Management Program, which is the program that I'll be discussing today, is a program within the hospital, but it's primary care based. So it's embedded within the primary care practices within Massachusetts General Hospital, or MGH, which I'll refer to it as going forward. We do have primary care practices both in the hospital at MGH as well as in the health centers in surrounding neighborhoods at MGH, and the Integrated Care Management Program sits within all those primary care practices. The program began in 2006 as a Center for Medicare and Medicaid demonstration project. At the time, we had 2,600 Medicare patients enrolled. Currently, we have over 4,100 patients enrolled, which I'll go into in a few slides later. We do include all payer groups now. So the program did start with Medicare exclusively patients, and we've expanded the program to include all payer groups. The program is really aimed at following patients longitudinally over time. We do focus on following high-risk, complex patients. And currently the program, it follows patients who are only patients who are in risk contracts or accountable care organizations. So that is the overview of the program, if you will, from 10,000 feet up. Next slide. This slide is really just a pictorial representation of the different population complexity on the pyramid, and it's just really meant to show the level of complexity of the patients that we follow within the program. So at the base of the pyramid is really the largest population of the healthy population. One tier above that, you have patients who, still quite a few patients, is still a fairly large slice of the pie, but they have a little bit more complexity. They're starting to develop some medical risk. Maybe they have one or two, perhaps, chronic medical conditions. But overall, they're still well managed. When you get to the tier above that, the tier in yellow, the high complexity patients, those are the patients that we follow in the integrated care management program. And here we're really talking about the top 2 to 5% in terms of complexity of patients within MGH. Those are the patients who have multiple medical problems, multiple chronic conditions, or multiple psychosocial determinants that are complex, causing increased health risk and poor health outcomes. And then at the very top of the pyramid, where we're talking about the top 0.05%, those are our sickest patients, and the patients who utilize the most services. Those are actually followed by a separate service. And then on the left of the pyramid are just some of the population health approaches that we use across the spectrum of patient complexity to follow patients at Mass General. Next slide. So just some statistics about enrollment and to give us sort of a more in-depth picture of the program and who we follow. As of a few days ago, when I pulled these latest data, we have over 4,100 patients who are actively enrolled in the program, and we have another 200 patients that we're in the process of engaging with and enrolling in the program, bringing our total to around 4,300 patients. We collect information based on our demographics of our patients, based on their risk score, as well as their age and their payer. So if we're looking at Medicare patients for the purpose of this talk, Medicare patients make up over 2/3 of our panel still. If you recall, we did start as a Medicare exclusive program, and they still represent the lion's share of the program at 69% of our patients in Integrated Care Management Program, or ICMP. They have a relatively high risk score, and their median age is 80 years of age. So not surprisingly, obviously, since you have to be over 65 to be at Medicare, they are our oldest patients, but they also tend to be some of our sickest patients, and they do make up the largest share of our panel. Next slide. Our overall objectives for the program are threefold. Since 2006, when the program has started, we've been focused on providing patient and provider satisfaction. So satisfaction is one of our three main pillars. Quality of care is our second main pillar. And then cost reduction is our third main pillar. And we really only see ourselves successful in this program if we're hitting that sweet spot in this Venn diagram where all three of those circles overlap. So if we're only reducing cost and providing satisfaction, but we're not impacting quality of care, then we don't consider ourselves successful. So we're really aiming for hitting all three of those main goals. Next slide. A little bit more information on the program, how it started, in terms of why the program was started. So the mission of the program is to improve patient care and outcomes through improved management and care coordination for the sickest patients in MGH's primary care practices. As I mentioned, the program began in 2006. When it began, it was a demonstration project for Medicare patients, and it was with fee-for-service beneficiaries at the time. It was initially meant to be a 3-year project, and the aim of the program was to decrease utilization, and the contract with Medicare was that we would reduce costs of the program plus 5%. And what we showed with the program over the years was that we were able to impact on all of those three aims. We were able to impact quality of care. We reduced hospitalization by 20% compared to a control group. We reduced emergency department visits by 13% compared to controls, and mortality decreased as well. We demonstrated high satisfaction both among physicians as well as patients, and we also demonstrated a substantial return on investment. For every dollar that the hospital spent, we saved at least $2.65. And because the return on investment was pretty robust, docs were satisfied, patients were satisfied, and we seem to be impacting the outcome measures, the quality of care. The decision was made to expand the program, and the program is now across not only at MGH, but across all the major partners hospitals. Next slide. So staffing. It began as a nurse-centric model, which when the program began in 2006 as a Medicare demonstration project, that made sense because most of our patients had medical complexity, and so we felt that nurses were the most well-equipped to handle these complex medical patients and coordinate care. Over time, as the program has evolved and the risk base for our patients has broadened, we've evolved the program to include a multidisciplinary team where we aim to have care coordinators with a variety of skills and backgrounds to handle care coordination for patients with a variety of risks. So we now have not only nurses as care coordinators, but we also have social workers, and we've begun to use community health workers as well. We have a central support for our care coordinators where we offer, we have a pharmacy team, including a pharmacist and a pharmacy tech. We have community resource specialists. We have a centralized nurse post-discharge care coordinator, and we have a data team as well that provides us with real-time data feeds to be able to evaluate our program in real time. We also are linked to other programs in the hospital fairly tightly. We have a liaison service with a mobile observation unit, which is a program that is able to send nurse practitioners to the home to do some fairly sophisticated care delivery within the home, including collecting blood work, delivering IV medications, and doing home-based assessments. And we all obviously are engaged with the primary care physicians fairly tightly. In terms of the management structure for the program, we have a medical director, a nurse, a clinical team director who happens to be a nurse, and a program manager who is trained in social work. Next slide. This is a representation of our model, which is, as you can see, has evolved over the years. When the program began in 2006, as I mentioned, it was mostly medical complexity for our Medicare patients. So the nurse care coordinator, the care coordinators at the time were nurses, and we did have some social workers who co-managed patients with the nurses for patients who had psychosocial complexity. A few years ago, as we started to take on Medicaid patients, we began to realize that Medicaid patients had different drivers of outcomes and health risk. Primarily, we saw a lot of patients with increased psychosocial complexity, and we realized that we needed a different set of skill sets oftentimes to manage that risk and care coordinate for those patients. And so we brought on social workers to function as care coordinators within their own right. And then most recently, as we've expanded the program to take on all payer groups, the three major payer groups, both Medicare, Medicaid, and commercial, we've begun to include community health workers as care coordinators as well to help coordinate care for patients who have primarily executive function risk. So difficulties with task completion, with navigation, health literacy, those types of issues that we don't necessarily need the level of a nurse. for a social worker to manage, but can be managed with a care coordinator, a community health worker. Next slide. So what are some areas of assessment and services we deliver? Well, as I've mentioned, our primary goal really is care coordination for our patients, and that's between the primary care physician and the specialist and the patients. Primarily within the network, we're talking about, although we do try and coordinate care outside of the network as well when that's necessary. Each care coordinator develops an individualized care plan for each patient that identifies the gaps in patient care and then develops a plan to overcome those gaps. We follow patients longitudinally. This is primarily, we offer primarily medical coordination because the lion's share of our patients are Medicare complex medical patients, but we do also offer mental health coordination. We have post-discharge coordination from hospital, skilled nursing facilities and rehabs. We are able to assist with durable medical equipment, pharmacy and medication reconciliation, transportation problems, and navigation within and to different office visits. We also deal with housing, food insecurity, and financial services are some of the areas that we can assist with as well. Next slide, please. So this is just a picture. This is sort of one of our, I love this picture because this is actually a real patient and one of our earlier patients during the demonstration project. But I think a picture speaks a thousand words, and this really shows where I think we can have some of the highest impact. And this was actually an elderly Medicare patient. So this is how the patient came to us with all her medications and quite a bit of medical complexity, as you can tell. And no one would be able to manage those patients on their own. I mean, it's just obviously it's an opportunity for polypharmacy, missing doses, and medication interactions, to say the least. So working with this patient, working with our care coordinator and the pharmacist on staff, we were able to simplify the medication list through reconciliation, narrowing down the medications that they needed, coming up with a clear list of what the patient needed, a pill box dispensing system, and you can see in the after picture, still quite a complex patient, but much more simplified and doable than the prior picture. Next slide. So what are some of the measures and outcomes that we look at? We really rely heavily on data for our program. We're a very data rich and heavy program. Our main utilization outcomes are hospitalization rate, emergency department visits, and 30-day readmissions. We also look at various performance measures that we look at every year. Typically, we'll pick different measures every year, and they range from things like having a end-of-life and goals of care discussion, number of days in hospice, number of missed visits, those types of measures. We collect a lot of programmatic data as well so that we can run the program efficiently and to the highest standards. We use this data for primarily management purposes. So we collect data on enrollments, how many opt-in referrals we get from primary care physicians, and patient demographics. We have data available to us on clinical conditions for our patients. We compile weekly data reviews that we share with all the primary care doctors and hospital-wide. Next slide. So this is just an example of what that data looks like that we compile and share hospital-wide and with all the primary care physicians, because we do see our calling really is to help primary care physicians with their complex patients. We feel that the data belongs to primary care physicians and the hospital, and we try not to take ownership of the data. And so this is just a slide, and what you can see on this dashboard, as we call it, is it just has information on who our patients are, how we're doing in terms of our outcome measures like admits per 1,000 and emergency department visits per 1,000. Next slide. This slide just shows you is an example of some of the clinical conditions that we collect. This is a fairly old slide from 2013, but the clinical conditions haven't changed that much, quite frankly. Of worth noting is just that we have about, over 40% of our patients do have mental health comorbidity. Almost half, 50% if you include substance abuse issues as well. So you'll notice on the x-axis we have all the clinical conditions. You'll notice a lot of the typical players for frail elderly patients with complex conditions such as diabetes, cancer, cardiovascular disease, renal disease, but we do have quite a bit of mental health comorbidity as well. Next slide. This is just a way for us to track a programmatic measure to track how many opt-ins we get. So there are two ways that patients can be enrolled in ICMP. We get a list of patients who meet criteria based on complexity and utilization from the hospital. That's the main way that the lion's share of our patients are enrolled in the program, but we do also offer a opt-in process, a referral process for primary care physicians. If they feel that they have a patient who's particularly complex, who they need assistance with care coordination with, we offer the ability for them to opt that patient in through an online, an EPIC referral in our health chart system. And this just allows us to track that. And as this shows, we're getting about 40 to 50 of those referrals a month now. Next slide. So finally, this is the last slide, and I wanted to just really sum it up with going over some of the successes and challenges of the program, some of the things we've learned over the last dozen years that we've been doing this. I would say that some successes, starting with successes, I think the biggest success is we know that it improves care delivery and care receipt for patients. There's been a good amount of a high degree of satisfaction both with patients and providers, and we do send out self-reported surveys on a regular basis to ascertain both patient satisfaction and provider satisfaction. The program is scalable. We were able to scale it from a Medicare-only program to an all-payer program within the hospital, Mass General, and then across all the different hospital systems within the hospital network at partners. And I would say that finally, an important success is that it works. It tends to decrease or at least contain cost and decrease utilization. Some of the challenges that we've faced over the years is these are complex patients, and our nurses and social workers carry large panels of complex patients. And like anyone who follows complex patients, PCPs, nurses, social workers, it's challenging, and it can lead to burnout, and that's a very real concern that we are acutely aware of. To some degree, we're a victim of our own success as well. The program is so popular among PCPs that one of the most frequent complaints we hear from PCPs is, why can't you take more of my patients? So unfortunately, we are limited in capacity. We have to randomly select which patients we will enroll in, which ones we will not, because we have a greater demand than we have capacity for. Another challenge that we've had is learning when to graduate patients from the program. As I mentioned, it's a longitudinal program, and patients love the program and patients want to stay in the program. But at some point, because we have greater demand than we have capacity, we need to, there needs to be an approach to graduating patients from the program to allow turnover to enroll new patients. And that's a constant struggle. I think there are also many social determinants that still fall largely outside the medical program. So there are a lot of areas of risk that are driving poor health outcomes for our patients, which even though we have a multidisciplinary team, still fall very much outside traditional medicine and traditional hospital care. And it can be challenging to address all those social determinants. And then finally, I would say one of our challenges is medicine is a very traditional field, and we are a very fast-moving program, and a fast-moving program within a slow-moving field sometimes can cause friction. And so we have not been a stranger to the shock of culture change and trying to change the culture within a hospital that has a lot of history and legacy with how programs are run. And so I think, for any program, for any hospital that's trying to do this, or program that's trying to do this, it pays to get leaders on board and to have a long view approach towards changing culture. So with that, I guess I'll say thank you, and I'm now going to turn this over to Robyn.
Thank you, Nicolas. That was wonderful. Going from one academic medical center with some of those struggles to another. I'm at Rush University Medical Center, and thanks, Peter, for that great introduction. Can we go to the next slide? So I really wanted to put this in the context of social work, because that's what I'm going to talk about today. And I'm going to talk about it because, as Nicolas just mentioned, he is a social worker on his team. Many people, or more people of late, I'm proud to say, have social workers on their team. But we've found at Rush, when you ask people what social work brings to the team, they're always very complimentary, but they don't necessarily have the evidence to show the unique position. And as we know, in this cost containment era, if people are going to fall from the team, which we hope that won't be the case, we in the field of social work felt like we needed to do a little more of the ROI just for this discipline, because it is newer to the team. It's not newer, but it's being recognized in a different way. So hence the discussion about social work, and I'm proud to say that APHA Journal did speak about a whole section on this recently in social work's role. So if we could go to the next slide. Part of what our basis is this study that took place in 2011, sponsored by RWJF. And it was really about healthcare's blind side, and talked to physicians who 85% reported that unmet social needs led directly to poorer health outcomes, but that they had a hard time sometimes getting to those needs, basically because there was a fear it was opening a Pandora's box, they didn't have the time, but most critically, they didn't have the resources for which to address those needs. So again, another reinforcement, when you look at all the social determinant issues, as Nicolas just outlined so beautifully as well, what gets in the way of health? We're seeing now that social determinants get in the way of health and social needs in a big way. And very often people on the team can't quite address those things. PCPs in this study said that if they would write 1 out of every 7 prescriptions they would be writing would be for addressing a social determinant issue. So this has incredible implications if you think about going from primary care, ambulatory care to the community, because people live in the community. They don't live in hospitals or their primary care physicians' offices. So if we could move to the next slide. So we wanted to look at social work's role, and we did at Rush a transitional care model, our bridge model, that looked at transitional care from the hospital to the home with a social work-based model, because most of the models were more of a medical focus. And we did a little pilot and saw that the reason many people were returning to the emergency room or readmitting to the hospital had more to do with psychosocial needs. So again, what can the social worker bring to the equation to address the blind side, particularly in the primary care environment? And we were pleased to see all the things that we know what a social worker could bring, but we had to really talk about what kind of support we would give. We were becoming medical homes at that point here at Rush and getting accredited. And we actually were able to show what we could bring, or discuss theoretically what we would bring to the equation to help the practices who were going to become patient-centered medical homes meet their accreditation. So a lot of things about self-management, linking to community resources, mental health interventions, which social workers do all the time, comprehensive assessments. And in all of this attempt, whether or not we talked about this at Rush or talk about it nationally, nowhere did we ever say social workers could do this work better. More social workers can do this too. And that was a way to avoid any, hopefully, any turf issues that were out there. And I think we've done quite well on that, acknowledging that nurses, physicians, community health workers all play a role. And but social workers can play that too. In our field, like many, the balance of the art and the science has been a tough one sometimes, and we err on the art a little more than the science. And we wanted to add to the evidence of why teams make a difference, and also, again, paying attention to how the social worker impacts not only the basic outcomes of utilization, 30-day readmissions, ED, et cetera, but again, provider and patient satisfaction, and then overall just quality of care, very similar to your Venn diagram, Nicolas. So if we could switch, I just want to talk about Rush for a second. Rush, I run the area called Population Health and Aging, and we really did start as absolutely just serving older adults. But it was recognized that our models that we were developing for care coordination really could be utilized well within a larger population. So we've attempted to be a little more payer agnostic, with some complications, because I have to get my policy point in here that we don't, as a nation, we haven't quite figured out how to pay for care coordination to the way it deserves to be paid for, both in the fee-for-service environment. There's some hopeful components there, and in the integrated care environment or the value-based contract. So there's work to be done. But our area is really one that addresses social determinant issues, kind of tries to cut across the fragmentation of care that often exists, particularly for older adults and their caregivers, look at people holistically, and try to develop best practices and promising practices to take forward, with an eye always toward equity, and trying to make sure older adults in particular do not fall through the cracks or are victims of sometimes ageist care. And by that I mean, and that's more of an oxymoron, sometimes you've heard, and I'm sure you've heard older adults say, oh, my physician thought that this was normal for somebody my age. So we really try to work and challenge that a bit in our role as care coordinators, because so often people don't know the context or the history of what patients bring to the equation. And I think some of what we do is an empathy building, understanding and empathy building for the team, to not just look at someone as, oh, so-and-so isn't adherent with the care plan, but maybe understanding the person might not be adherent because they don't have any food on the table, or they don't have any transportation to get to Walgreens or CVS or whatever to pick up their medications. So next slide. So this kind of goes through a lot of our services here. I'll go through that. Let's jump though to the next one. So what we did was we started what we call the Ambulatory Integration of Medical and Social, or AIMS model. And we utilized master level clinicians, social workers, to wrap around the team and be hopefully integrated in the team. We literally have a button, just as someone would refer, a PCP would refer to a cardiologist, they would be referring to a social worker. And we did a lot of rolling out and talked about what social work could do and how we could be useful in terms of a whole range of things, from motivational interviewing to self-management techniques to just engaging in a different way, counseling if needed, and care management activities. So we really did make the case, and we had to make it initially, of, you know, why bother with us? And we really have shown, and people see, we now have the problem, like you were talking about, Nicolas, we have greater demand than supply. 10 years ago, our head of our physician practice looked at me and said, oh, this isn't going to go. Nobody's going to want a social worker around. And now he laughs because everybody wants a social worker around. It's just trying to make it all happen. But within the context, we knew we needed to do this AIMS model to protocolize what social workers bring to the team and what a difference they make in patient and caregivers' lives. And so we did that through looking at this model, and most of it's telephonic. It can be longitudinal, but it's very much one that relates to goals and attainment. So we're able to go in and out of people's lives as they need us, and they're able to come in and out of our social work role when needed, when they need us. So it works out well because, of course, we know what it's like to be able to reach capacity and not serve people. So we try to, end with people when they've met their goals and get involved again when they have greater needs. So if we could go to the next slide. I mentioned our electronic medical record, and this is a social service referral for us. So if we can jump to the next one. I'm conscious of time, but I want to just touch on Mr. W, who's a 78-year-old African-American man living in a large metropolitan area and presented with a lot of physical issues, but also financial issues, depression, and very much a transplant history. We had 2 in-person contacts with him and 6 telephonic. So I'm also trying to speak to the efficiency of this model at times. And we know not every practice can have a social worker. So our social workers cut across practices too, to build kind of an economy of scale notion that sometimes every practice doesn't need a whole full-time social worker. But the clinical skills we used are multi. We start with a basic assessment to see what's going on, psychoeducation, interprofessional collaboration. Very often, people don't know as part of the team who's working with one another. So the AIM social workers, often the one that brings the team together in a way that hasn't been brought together before. So goals of care can be discussed and connecting to benefits. And we were able to help Mr. W connect to benefit programs that he was unaware of, reduce some of his financial distress. He was engaged in psychotherapy for the first time as a 78-year-old man. And he was able in the end to self-report that his confidence in just his ability to manage chronic conditions and relate to the hospital system was improved as a result. So if we could just go to the next page. So what did the social worker bring to this? As I mentioned, the care management tasks, some specialized skills. And what I wanted to show in the right-hand column is the average time spent addressing these non-medical needs within the context of primary care was, some of you may think that was long, but really when you think about how many contacts, it's probably not, it's not unusual. For me as a director, I thought, oh, this is not bad for getting what you get as a result. And those contacts for those 155 minutes included many other people. It didn't include, of course, documentation. But if we can skip to the next slide. This was our pilot where we were able to show great results for, not great, but good results for hospital admission reduction, 30-day readmissions, and ED visits. And what was interesting about this, we also talked about provider satisfaction, and we have quantified those that we did have an impact, and we also have had an impact on depression scores quite significantly, because again, it's hard to not talk about the psychosocial without including mental health, behavioral health. So we were able to show and build in a way that we then received Commonwealth funding to do more of a quasi-experimental study, and our data is just coming back from that work. But so far, things are showing that we, again, have reduced depression scores significantly, that families were engaged in a different way, and it's looking like providers were more satisfied. And then if you look to the next slide, you cannot hear at least here, I'm sure in Massachusetts General too, the attention to provider satisfaction and burnout. It's, you know, written about in the New York Times, and we're hearing about it a lot here at Rush. And, you know, we thought, wow, we had thought about this a long time ago. How do we tie this model and teamwork to reducing some of that dissatisfaction? And I think we're beginning to see that that does make a difference, and we're excited that we're helping the team address those non-medical needs, those needs that were often the blind side that we talked about initially. So we have, my next page are some of our publications. So we can look at those more in depth if you have any interest, and hopefully there'll be more very soon. And then I think our growth opportunities are interesting. The next slide, the last slide, because we're continuing to refine the model and identify the best practices and their impact. We are very much trying to help CBOs in the community be able to cross to the hospital too, because this could be a bi-directional model. It could be the hospital staffing up the social workers, but it also could be the community-based organizations, the Aging Network, going into the hospitals to provide this kind of care coordination. So we're looking for partners who want to learn more about this. We have a grant from the Weinberg Foundation to spread this model across the country. And some of these sustainability avenues from a reimbursement perspective are talked about here in terms of chronic care management codes, of course, looking towards some of the, you know, merit-based system, value-based contracts, ACOs, to see how we will fit in the future. And to the last slide, in building our future, we have developed a Center for Excellence here at Rush that this is folding into. Most excitedly, though, we now have fully funded a National Academies report that will begin in April addressing social determinants. And this is coming from our Center for Health and Social Care Integration, 2 different centers that we started at Rush in a couple-year period. So we are so excited about the National Academy report. It's kind of modeled after the Future of Nursing report. It's definitely will speak to social work, but social determinants more broadly, and different professions' roles in the context of that too. So on that note, I'll end and probably switch it back to Peter.
Great, thank you so much, Robyn. We really appreciate your presentation as well as Nicolas's presentation and time today. At this point, we can go ahead and start some questions and answers. So if you will visit the questions portion of your toolbar, we've got a few here. We can go ahead and start with some of those. Let's see what I have here. Okay, and if you'll, one last thing on the questions, if you'll try to be as specific in your question as possible, especially with acronyms, that would be great. Let's see here, the first one. Why did you decide to change from a nurse-centric model? I guess that's directed towards Nicolas.
Yes, so we decided to change from a nurse-centric model as we started bringing on, quite frankly, non-Medicare patients. So as we brought on Medicaid patients and commercial patients, we began to see that our patients had greater psychosocial complexity, and we felt that there were other allied health professionals besides nurses who might be better equipped to lead care coordination for those patients. And so we currently have a scenario where, and no patient has, lives in a silo, obviously. Most patients have both medical and psychosocial complexity. And what we do is for patients who have predominantly medical complexity, we have a nurse care coordinator lead with that patient, and a social worker or a community health worker will co-manage with them as a following along. And conversely, if we have a patient who's predominantly has psychosocial complexity, we have the social worker lead as the care coordinator, and we have the nurse or community health worker then co-manage as the follow along for the medical complexity problems or executive function problems.
Great, thank you so much. Okay, this I think is more of a clarification question. Is there a special definition of health that is used for this overall presentation? I'm assuming that it reflects the WHO definition. If not, can you clarify?
I don't think we got together on that, but I think what I heard both of us saying was that health really is a compilation of one's physical needs and conditions, as well as mental, as well as social and environmental. Would you agree with that, Nicolas?
100%.
Interesting
Great,
question.
here's another one. Yeah, it's one that you have to kind of think about for just a second. Let's see, here's another one here. Why are social determinants, those that can be changed, considered outside? Is that because there's no compensation for those? And they're saying, shouldn't we move away from a medical model and traditions? It sounds like you guys are starting that process.
Yeah, I think Nicholas and I would agree with you wholeheartedly that they should not be outside, but unfortunately, our payment system still sees them as a bit outside. I think CMS, in its attempt to fund the accountable health communities, is nodding to social determinants as maybe having an impact on overall health outcomes, but even in that innovation, they're not necessarily paying for those social determinants. They're talking about screening for them, but not supporting what's the risks that are found in that screening.
Yeah, I agree. And I mean, like Robyn said, I think part of it is payment. And actually, like Robyn, you had mentioned this in your slide. You had one slide in this. There are a variety of factors why it's challenging. One of them, a large one, is payment. But there are other factors as well in terms of physician comfort level, how physicians are trained, how nurses are trained. So it goes all the way back to our education, our comfort level, how our schedules are made up essentially. Having a 15-minute visit to focus on medical complexity just quite frankly doesn't give doctors enough time to delve into these complex issues, which take a lot of time. And as Robyn pointed out, I mean, the mean time was 155 minutes. How are you going to do that in a 15-minute visit when you've got when you also have to review the heart failure, the kidney function, the high blood pressure, et cetera? So it's complex. But I will say I really am heartened by the fact that I'm hearing more talk and enthusiasm about this now than I ever have in the last 15 or 20 years.
It's come of age.
Yeah.
Great, I have another question for you. Are you finding that those who are entering the workforce today or in the last few years are coming with the skills necessary to help this population? Do you think that there are skills that maybe educators listening could work into programs that would help them better serve this population?
For me, the answer is yes. I've noticed some changes, but yes, there's still more work to do. And I think as long as it's considered an elective kind of thing to address population health or social determinants, it's always going to be viewed as an elective and not integrated into the overall. So I guess I just wish we could keep pushing for that.
I would agree with that. I mean, I think on the one hand, I think if not the skills, then at least people have the awareness when they're coming into it now. I mean, I think nursing and medical students and social workers probably more than ever, more than us traditionally. But I think everyone now, when I see trainees, they're aware of these issues at least. Whether we have the skills to address them fully, I think is yet to be determined. I think part of the complexity has to do with quite frankly, with the structure of our medical insurance system in this country, where it's through the insurer it's through the employer, and medical care is separated from the rest of our safety net structures within society. So in nations where those are connected, it's easier to make the connections and getting everyone talking to each other between health and food and architecture. And I mean, it's just harder in this country since it's an isolated profession and an isolated reimbursement system.
Great point.
That's great. So if you could change anything about your challenges that you faced and wave a magic wand to make things a lot easier for yourself, what would you have done?
Can you say that one more time? I'm sorry.
Sure. Speaking and looking back
you went
at the
out on my phone. Yeah.
Oh, I'm sorry. Speaking from looking back at the process of implementing and getting your program set up and then where you are today with your programs, if you could go back and wave a magic wand to make things easier for yourself, what would you have done?
I guess what I would say is the one wish I had is that we had rigorously tested out the efficacy and impact of all the different allied health professionals functioning as care coordinators within the ICMP program, the way that we as rigorously as we had with the nurses with the Medicare demonstration project when we started. So when we rolled out the first program in 2006, we had a control group, and it was a very robust process. We then expanded the program based on the success of that program. We expanded it, and there were some assumptions that went along with that, namely that the program that worked for Medicare patients managed by nurses could work as well for non-Medicare patients, and followed by non-nurses or other folks, other allied health professionals. And while that has face value validity to it, it becomes complicated when you start talking about panel sizes. Now, should social workers follow the same number of patients as RNs? How do you adjust for that? So as we've broadened the program and expanded it, and we've run into a lot of programmatic weeds that I wish we had more robust data to help us, to help guide us.
Well, Nicolas, maybe you want to use our AIMS model and play it out with your team. That we'd be very excited by that.
Yeah, it's certainly something that I'm going to do a lot of reading on, yes.
I think our biggest my to-do would be starting with a clear sense of where we're going to get the cost and utilization data from. It is very hard to get in a fee-for-service environment, so in a more timely way.
Great. Thank you so much to our presenters today. That's going to put us here at the top of our time. I'm sure that we could spend another hour talking about this in more detail, but we'll have to save that for another day. So again, thank you so much for taking your time to present with us. And Peter, I'm sure you'd like to say a word of thanks as well.
Christy, if I could only get my phone working.
All right, well, I'll say thank you on behalf of Peter and the center as well. So that concludes today's webinar. Our next one in this series, looking at the care for frail older adults, will be titled Issues in the Supply for Frail Older Adults for Workforce Supply for Frail Older Adults in Primary, Geriatric, and Long-Term Care. And that will be held on Tuesday, April 10th at 3 p.m. Eastern Time. This is a little bit of a different time from our first two here, so please note that on your calendars for April 10th at 3 p.m. Eastern Time, and look for registration emails coming soon. Thank you all so much again.
Thank you.
Thank you.
Research. Visit a dermatologist at Rush